All right. Welcome, everyone. Thank you for joining CWEA's third COVID-19 update webinar with the California Association of Sanitation Agencies, better known as CASA. My name is Arvind Akela. I'm the incoming president and the engineering director for Silicon Valley Clean Water. Today, we are discussing wastewater surveillance with speakers from CDC, EPA, the Orange County Sanitation District, and CASA. Next slide.
Hey, Arvind, if it's okay, let's just wait another 2 minutes so we start right at the hour, if that's okay.
Okay, that's fine. So, okay, let's get started. Let's go to the next slide. All right, welcome everyone. Thank you for joining CWEA's third COVID-19 update webinar with the California Association of Sanitation Agencies, also known as CASA. I am Arvind Akela, CWEA's incoming president and the engineering director for Silicon Valley Clean Water. Today we are discussing wastewater surveillance with speakers from CDC, EPA, the Orange County San, and CASA. Next slide. We want to thank our sponsor, Wastewater. Wastewater is driven to be the water firm of choice in California by providing innovative solutions that support sustainable development. They strive to be the water firm of choice for employees by valuing and practicing continuous improvement, having an ownership mentality, respecting people, and giving back to the community. In celebration of their 30th anniversary, and in response to the need for resources during the COVID pandemic, Wastewater has donated over 30,000 meals to communities in Arizona, California, and Oregon. So let's give a shout out to Wastewater. Thank you. Next slide. CWEA's volunteer leaders, trainers, and staff are continuing to work hard for our members. We have held 18 online training webinars so far, and even more are coming up. This month, 2 WIPE webinars hosted by CASA and CWEA, 2 electrical and instrumentation webinars, and a special webinar, Water Board enforcement webinar with Jim Fisher. For July, we're working on 4 lab certification prep training webinars, an operations maintenance webinar, and then engineering and research webinar. You can learn more at our website events@cwea.org. Next slide, please. We have started planning for the next annual conference, AC21, which is occurring in San Diego. CWEA's current president, Wendy Wirt, has established the theme. It is, "You are all environmental heroes." That's the theme. And we are holding out for our heroes. We're looking for 2 more volunteers to join our education program team, also known as EPT, to help plan the training sessions. We're particularly in need for volunteers with experience in operations, maintenance, or electrical instrumentation. You can click the link how you can volunteer for AC21. Next slide, please. So we get a lot of questions about the virus. So I'd like to share some background before we start the panel discussion. Here's what the CDC, scientists, and WEF have told us. To date, the scientist community has found no evidence of viable COVID-19 virus in wastewater system. The wastewater surveillance studies we're about to discuss revolve around detecting RNA fragments of the virus in wastewater. We believe this is inactivated virus since no scientists have been able to culture infectious virus from wastewater. While there is still a lot we don't know, it appears contracting COVID-19 through exposure to wastewater is unlikely. As soon as scientist info becomes available, we will share it. Next slide, please. So on the screen is CWEA's standard presentation disclaimer. If there's any media on the call, all speaker presentations are off the record. I'm not going to read this whole, so we'll move on to the next slide. So our moderator today is Greg Kester. Greg is the Director of Renewable Resource Programs for the California Association of Sanitation Agencies and California Coordinator for Information about the Coronavirus in Wastewater. Greg is CASA subject matter expert on matters pertaining to the renewable resources and manages emerging issues related to biosolids, renewable energy, recycled water, climate change mitigation, and more. Greg, I'm turning it over to you now.
Thank you very much, Arvind, and welcome everyone. It's a pleasure to have so many participants again on our third webinar addressing the potential and real impacts of COVID-19 to the wastewater sector. We remain in an unprecedented and unique circumstance and hope you're all safe and faring as best as is possible during these times. We continue to want to ensure safety for our workforce, especially those in collections and others who may be exposed to COVID-19 and wastewater prior to treatment. We're also interested in the potential of using wastewater-based epidemiology as another metric to assess shelter-in-place policies, especially given the fact that society is reopening across California and the country, and in anticipation of a possible second wave of COVID-19 in the fall. We've assembled a well-informed experts for today's panel to discuss COVID, the use of wastewater surveillance as a quantifiable metric, what is needed to ensure analytical accuracy, and how to implement and coordinate a national response. We can't overstate our appreciation for them to take time and address us today. So a big thank you to all of our panelists. With that, I think we have some housekeeping on the Zoom platform. The chat room is something which can be used for comments, and also we have a few poll questions throughout the webinar, and you can provide answers in the chat room as well. And please use the Q&A option for questions. I will synthesize these questions and then use them for the panelists at the end. Panelists may also try to respond to them during the course of the webinar. And the raise hand feature is not going to be used in today's webinar just because there are so many participants. It really wouldn't be very practical. And we start with an initial poll question. If you can all respond to this question about your organization. What type of organization do you work for? And you can see a few options here for you to respond. And if you do respond as other, you can list that in the chat box. So we'll give you a little time here to respond to the question. Okay, we can see our responses here. It looks like a majority are with large municipal agencies. Medium-sized ones as well are well represented, as are a number of others. So thanks very much. And with that, I'd like to introduce our first speaker, Dr. Mia Mattioli, who serves as the Domestic Activity Lead for the Centers for Disease Control's Environmental Microbiology Lab of the Waterborne Disease Prevention Branch within the Division of Foodborne, Waterborne, and Environmental Diseases and the National Center for Emerging and Zoonotic Infectious Diseases. Her work focuses on environmental health research areas such as drinking water, irrigation water, wastewater, recreational water, soil, food, water distribution systems, and the development of advanced molecular detection technologies. The research is focused on the intersection between the environment and human health, with a specific interest in the relationship between and fate and transport of fecal indicators and enteric pathogens in various environmental matrices. Dr. Mattioli leads the environmental investigations of waterborne outbreak responses by the CDC, and she's the technical lead for assessing the use of national wastewater surveillance systems to inform the COVID-19 response. She has a Bachelor of Science in Biological Engineering from the University of Georgia and a Master and PhD in Environmental Engineering from Stanford University. So with that, I'd like to welcome Dr. Mattioli.
Hi, Mia, you might be on mute.
I apologize. Can you hear me now?
Yes.
Thank you. Sorry about that. I appreciate the opportunity to speak today about our work at CDC evaluating sewage surveillance for the COVID-19 response. Trying to change. I'm not sure I can change the slide. There it goes. Slowly. Thank you. I believe Mark is going to talk about surveillance efforts at the state level a little bit later, but I wanted to start by giving a quick overview of the role CDC normally plays in disease surveillance for the United States at the federal level, in order to give you all context for the role CDC would envision playing in a sewage-based disease surveillance system. The graphic on this slide describes the data flow for our nationally notifiable disease surveillance system. Broadly, case and symptom-based data are captured by hospitals, healthcare providers, and laboratories, which are then sent to local, regional, or state public health authorities, who then share the compiled data with CDC. Within national surveillance, CDC is responsible for several different activities with these data, including coordinating the collection and storage of the data, summarizing the data for sharing back with the states and public, analyzing data to provide public health recommendation and guidance, and finally supporting inter-health agency communication around the data for public health action. As many of you are aware at this point, sewage surveillance could be a promising new tool for our public health toolbox in the COVID-19 response. Because the virus is shed in the feces of up to 80% of infected individuals, both symptomatic and asymptomatic, and at concentrations of up to 100 million viruses per gram. Since the majority of feces in America will be flushed into the sewers and arrive at wastewater treatment facilities within hours, sewage can be seen as an efficient pooled fecal sample that can be used to estimate community level or even sub-community level infection prevalence. A sewage-based surveillance prevalence estimate would be unique from current case-based estimates because it would capture subclinical infections. It would be independent of health care seeking behavior and testing access, and would finally provide data within a few days versus up to several weeks for other surveillance data. As part of the public health toolbox, we envision health departments using sewage-based surveillance data to inform response decisions. However, sewage-based surveillance data is not intended to replace traditional surveillance indicators, but instead has the potential to complement case and symptom-based surveillance data, which target only the top 3/4 of this surveillance pyramid you see pictured here. While sewage data isn't perfect, the imperfections of sewage data are distinct from the flaws of other testing-based surveillance systems, which means sewage could potentially provide resolution to conflicting clinically based indicator trends. It could also provide infection data for communities where testing isn't available, and potentially provide an understanding of sub-county infection variability where the highest resolution for most other surveillance indicators are only at the county level. Finally, sewage could provide information on viral circulation within a community during subclinical phases of the outbreaks when no cases are being reported. As a COVID-19 surveillance indicator, methods for collecting, quantifying, and interpreting sewage-based surveillance data are still very much in development. However, we think we can still drive the car while we build it, and based on the current state of the science, sewage really has the potential to provide several types of information for the response in the near term. Sewage will likely be most useful for measuring changes in overall infection prevalence within a sewer shed, and by sampling within the sewage distribution system, it may even provide trends at the institutional level, for example, long-term care facilities, prisons, or even universities. Based on current estimates of method detection limits, sewage has the potential to also be useful in certain communities for monitoring the emergence or reemergence of COVID-19, as there evidence that the sewage signal could precede clinical signals such as hospitalizations or confirmed cases. And sequencing of the viruses found in sewage has the potential to track circulating virus evolution and global origin upon emergence in the US. Finally, eventually sewage surveillance could have the potential to estimate overall infection prevalence within a wastewater surveillance system. However, more clinical data are needed for sewage before sewage testing can be used to confidently estimate overall infection from sewage. And the reason for this is because converting sewage concentrations into a community prevalence is intrinsic. Oh, I'm sorry, it's changing slides. Gonna have to go back one. Apologize for that. Okay. Apologize. The reason for this is because converting sewage concentration into a community prevalence is intrinsically dependent on clinical data describing the concentration of viruses in feces of infected individuals, and those data are not available yet for cases in the US. For example, the schematic here shows a model CDC developed that uses data on the pathogen concentration in sewage to estimate the prevalence of infected individuals in the sewer shed. The model incorporates SARS-CoV-2 specific parameters, such as the amount of feces produced per person per day, the survival of the virus in sewage, and the limited data available from Southeast Asia on the virus concentration shed in feces, each of which is represented in the model by a distribution of values capturing their inherent variability. Finally, we're working excuse me, sorry about that. The graph on the right shows the real output of our model given specific virus concentrations in sewage on the x-axis and the output of the estimated community infection prevalence on the data samples collected on the y-axis. However, what you can see here is that with every tenfold change in the parameter describing the virus concentration in infected feces, the estimated prevalence will also change tenfold. Therefore, until more fecal data are available, we can only be confident in the information on presence and trends in the community infections from sewage data. CDC is taking a phased approach to assessing the utility of sewage surveillance to inform the COVID-19 response. This includes an assessment phase where we're working with industry and academic partners to evaluate existing SARS-CoV-2 sewage data by retrospectively evaluating how the sewage data could have been used alongside case and symptom-based surveillance data to track decisions to make decisions in the response. If our assessment phase demonstrates the usefulness of sewage data to the response, we'll move to our operational phase, where we plan to expand our network of testing to sentinel sites across the US that will be supported through increased sewage testing capacity at both CDC and EPA. During the operational phase, we'll also be developing a process for states to submit sewage surveillance data into a repository housed at HHS for national summary and analyses to better inform rapid public health action nationwide. As I mentioned, our assessment phase leverages existing sewage data from external collaborators, including the University of South Carolina, Stanford University, and Hampton Roads Sanitation District. These data come from over 50 wastewater treatment plants, including many in California, as well as others in South Carolina, Texas, Virginia, Oklahoma, Massachusetts, Ohio, Illinois, and Arizona. These data come from samples collected starting as early as February and cover distinct areas with various disease levels and ongoing community mitigation strategies. The assessment phase consists of several activities when evaluating the data sets. First, by comparing efforts from multiple groups, we're determining the minimum data needed to compile sewage data resulting from different sampling and detection methods, which will be critical when setting up a national system until a standardized method is utilized. Next, we're comparing different methods for measuring the virus in sewage and the impact those differences have on predicted infection trends. This includes comparing sample concentration methods, detection assays, and parameters for normalizing sewage concentrations across time and utilities to account for variable dilution from non-human inputs into the system. We're also comparing our model to those developed by Stanford and other researchers to determine robustness of the public health interpretations from sewage. Finally, we're working with the CDC response data analytics and epidemiology task forces to compare these sewage data alongside clinical disease surveillance indicators in order to determine the usefulness of sewage data to the response. The metric of usefulness for sewage data in the response fall under two categories. First, the ability of sewage data to provide information on the emergence and disappearance of the virus in the community, and second, the ability of sewage to predict trends in infection prevalence. For both categories, we're evaluating the timeliness of sewage surveillance relative to clinical surveillance data, and we're determining the minimum infection prevalence that sewage surveillance can measure based on the detection limit of the different testing methods, and determining what sewage concentration changes are associated with meaningful clinical changes in the community. There's clearly much work to be done to understand the application of sewage-based disease surveillance in the COVID-19 response. However, in the near term, CDC plans to provide leadership in this disease surveillance effort in the form of awareness and support for our public health partners. This includes setting up a website within the response to provide consistent messaging, updates, and communication for ongoing activities by both the utilities and health departments. This will also include support and coordination around the use of sewage surveillance within the response for our state and local health departments, who, as many of you know, are at full capacity working on the response, but are also being bombarded with large proposals and submission to develop sewage surveillance systems that claim to do things that science may not yet support. Finally, we're working to prepare for our anticipated operational phase through increasing communication between health departments and sewage testing labs, selecting sentinel surveillance sites, gearing up the national lab at CDC, and planning an assessment of targeted uses of sewage. If sewage becomes a useful public health surveillance tool for the COVID-19 response, CDC envisions leading support and coordination of this work long-term through the establishment of a national wastewater surveillance system, or NEWS. This system would house national sewage data similar to existing disease surveillance systems I mentioned earlier in the US for rapid interpretation of public health action, as well as integration with other surveillance systems. Also similar to our existing systems, it would be supported by a national CDC laboratory to provide testing capacity for sentinel sites, evaluation of methods, and the potential surveillance of other health targets captured by sewage. Finally, this type of surveillance program would provide support and capacity building at the state and local level and have several key partners, including EPA, stakeholder organizations for both water and health like CWEA and APHL, and both academia and industry. While sewage surveillance has the clear potential to be a promising tool for the COVID-19 response, this tool can only be useful for public health if it consists of robust and high quality data. This includes the incorporation of new clinical data into the models as it becomes available for estimating that overall infection prevalence within a sewer shed, as was mentioned earlier, but possibly more critical for the successful public health application of sewage surveillance in the COVID-19 response is the data quality for the accurate, representative quantification of virus in sewage. This includes understanding the performance and coordinating the standardization of sewage sampling plan design, sample collection procedures, testing methods and data quality controls, and finally approaches for data normalization. In order to tackle these big data quality issues, we're working with our federal partners at EPA with expertise in environmental sampling and testing protocols to develop recommendations for a standardized approach for each sewage testing use case. And with that, I thank you for having me, and I'll hand it over to Jay Garland at EPA to describe the work they're doing to ensure robust and quality sewage sampling and testing data for the response.
Thank you very much, Mia. Tremendous. And I think we have another poll question here before we get into Dr. Garland. Monica, if you can put that up. And the question is whether you support wastewater-based epidemiology as an alternate metric for assessing shelter-in-place policies. And this is a yes, no, an unsure, or another. And the other, if you could write in the chat box. And just as a reminder as well, folks, if you could please use the Q&A function for your questions to the panelists. The chat function is really more for these types of questions. Thank you. And it looks like there is strong support for using wastewater-based epidemiology as an alternate metric, with a lot of folks unsure. Probably after this webinar, we may better be able to answer that question. So thank you very much. And with that, I'd like to introduce Dr. Jay Garland, who joined EPA's Office of Research and Development in 2011. Dr. Garland received a PhD in environmental science from the University of Virginia, and he spent over 20 years working on NASA's efforts to develop closed bioregenerative life support systems for extended human spaceflight. NASA recognized him for innovative technical achievements 4 separate times. He's worked on a range of topics, including methods for microbial community analysis, factors affecting survival of human-associated pathogens, and various biological approaches for recycling waste. His current efforts focus on advancing innovative approaches to water infrastructure, including decentralized water reuse and mitigating risks associated with antimicrobial resistance in the water cycle. And with that, I'd like to turn it over to Dr. Garland.
Well, thanks, Greg. Thanks, everybody, for tuning in today. And I appreciate Mia's intro because it really set the stage, kind of outlined the major issues with trying to use SARS-CoV-2 monitoring, and also kind of illustrates the close collaborations we've had over the last few months. So I'm going to give you our perspective on what we've been doing in the US EPA Office of Research and Development, which is kind of the research arm of EPA. Pretty much all the work that I'm going to be talking about is associated with folks and staff here in Cincinnati, Ohio. It's where one of the EPA labs, one of the larger ones, is located. There's a number of people involved in this work. This kind of illustrates both the collection of people in ORD, but because the method can't be developed in isolation, it really involves understanding how the method operates and kind of performs in sewage, but also understanding sewage dynamics and the role that plays on the signal. So you see a number of both local partners that both Cincinnati Metropolitan Sewer District have been a great partner in really understanding their systems. Also the Associations Ohio that we've reached out, and I'm going to talk about also our connections to the public health agencies, both at the county and state level, and end with kind of a state level effort that really tries to bring all that together, the analysis, the utilities, and public health. So one of the great things about kind of the unintended benefits of this crisis has been that there's been a lot of discussions amongst people across the country and across the world who are experts in this area. I was fortunate to serve on a Water Research Foundation working group that involved Mia, and that's where I first met her, but also involved Gerten Medema from the Netherlands, who published some early work on this. And I loved his quote here, the kind of the image of the sewer as a mirror of society. And I think that's an interesting concept to apply. And really the issue is, okay, can we see ourselves clearly? Or how distorted is that view when we try to look into the sewer and see ourselves and really see our back towards the community and what the infection rate is? So I'd say that's really the biggest, where I see our role is really trying to understand and disentangle that potential distortion. And you notice that on this figure graphically, there's 3 knobs on the side of that. And I really feel like as scientists, here we are, we're trying to dial in these knobs to really try to get rid of the noise and really understand a clear signal between what we see in the sewer versus what's going on in the community. And that's challenging. And I'm shouting out to another person who was on that WRF panel, Jeff Solar, who's a great modeler and really understands complex issues. And his quote was, man, there's just too many knobs on this problem, right? You try to work on too many knobs simultaneously. And part of the problem is given the speed of the issue, right? The need to develop solutions quickly, we really are trying to work on these knobs almost simultaneously. And that's a challenge, but one that I think is worthy of our effort. So these three knobs, I'd break them out into, one, optimizing the analytical methods. And that's really what the detection levels are, what your recovery efficiency is, what's the inhibition of the sewage in this analysis. And those are very important. But so is accounting for the dynamics in the sewer. What is the decay and degradation and dilution of that signal that's going on independent of the method, but really just are based on dynamics in the sewer due to maybe dilutions from stormwater events, industrial flows, just the nature of the sewer itself. And then finally, it's trying to look back into the community. And as Mia mentioned, there are multiple and imperfect estimates of fecal shedding, right, at present. We can model it, but it's still kind of rough. But we really need to involve kind of relating back into the community too. So these are three knobs that we're working on simultaneously. I think there's no way around it. We don't normally, traditionally, we might just work on the method and optimize it and validate it and then publish the validated method and say, hey, go out and use it. But at this point, we really need to work on these things simultaneously. And that's what I'm going to kind of describe what we've been doing over the past couple months to dive into this. So our approach, we've got two main groups in ORD here in Cincinnati that are working on this. One is looking on a little bit longer term method development, both the molecular signal, which is pretty much everything I'm going to talk about now moving forward. But that group is also looking at the cell culture method, looking at can we detect viable cells? As it was pointed out earlier, we have not detected live or infectious virus in sewage yet, but it's still worthy of study. So that work is going on. But also, like I mentioned, we need to apply quickly. So the other group is really doing very rapid method assessment. We hope to get done in July and really then move on to application of the method in a phase one kind of pilot monitoring, which, the current projections run through December, and then I would assume is going to continue after that. It's really just all dependent on the dynamics of the pandemic. Now, you notice there's arrows, with time, we think we can maybe improve or optimize the method over time, but I think there is a need to kind of apply a best case method relatively soon and apply it in the field, get comfortable with it. And as I think Greg mentioned earlier, really trying to maybe get positioned for best understanding and monitoring for potential increases in the fall. So let's talk a little bit about whoops, going to go the wrong way. Let's talk a little bit about the method and what we're doing. So we start off with composite samples, and it's given the industry folks here, you guys understand what that is, and the reason for it is because it's an integrated picture of the community, right? It's not a grab sample. You're really looking at a integrated snapshot of what happened over the previous time period. So we start with composite samples, and then we centrifuge it, further use membrane filtration so that we get a relatively clean sample that we can ultrafilter and concentrate. So all those arrows on the bottom, the pellet, the filter, the concentrate, they represent different size fractions in essence of the sample, and we're analyzing every one of those for the signal. We also are looking at spiking the sample going in and analyzing the sample before those steps, just the overall composite sample for analysis of what we spike in. And these are the surrogates that we would spike in. We'll talk about that a little bit more. And then also endogenous targets, things that we don't spike in that are there in high enough levels normally that we can then evaluate them before we try to look at the recovery fractions and then compare our method performance by looking back at what we got from the initial sample before that processing. So in terms of the recovery efficiency, I mentioned looking at using spiking control. We used an organism called Phi6, which is an enveloped RNA bacteriophage. So it's a virus that infects bacteria. It is an enveloped RNA virus, which SARS-CoV-2 is. So it's similar to that, not identical, but similar. That's why it's a reasonable surrogate. It's easy to use because in terms of growing it up and for spiking, you grow it on bacterial cells, which is much easier than when you're trying to grow cells on human cell lines, which there are other coronaviruses like 229E and OC43, which are strains of human coronaviruses, which we are planning on using. It requires a little bit more difficulty in culturing, but we'll then also kind of spike those in. What we know now from the work when we spike Phi6 in, and this is known too with previous work with SARS-CoV-1, when you spike in these cultures, you get rapid loss in wastewater, like 3 orders of magnitude or more, very rapidly. So it's hard to interpret that as a true recovery efficiency, right? Because what you're seeing there is that really simulate what's happening to the SARS-CoV-2 virus as it enters through fecal matter into the wastewater. That may have happened a little bit of time ago, right? It's 3, 6, 12 hours, depending on the residence time of your sewer network, right? So there's the kind of an immediate loss in signal that is somewhat difficult to interpret, but you need to do these spiking controls so you can at least assess your performance. In addition to that, I mentioned these endogenous targets that we can use. There's crassphage, which is a non-envelope DNA bacteriophage. Again, another phage. In this case, it's DNA. It's not envelope, so it's not similar at all to how you would expect SARS-CoV-2 to behave, but it is a virus that you can look at through this processing. Same thing with the pepper mild model virus, which it's a non-enveloped RNA plant virus, so it doesn't infect humans, but it's found in human feces due to the peppers that we eat. It's actually in remarkably high numbers. And crassphage is specific to human fecal matter because it infects bacteria that are specific to humans. So they're both at high enough levels where we can use them as spiking controls, but they also allow us to, to look at the method evaluation. So a combination of spiking and endogenous markers for kind of looking at recovery efficiency. Also, that's kind of the methodology. I want to move the sewer dynamics very quickly. And here you're talking about the decay, degradation, and dilution in the sewer, as I mentioned earlier. And we're really using Cincinnati Municipal Sewer District. You're going to get to know Cincinnati much more than you probably knew before. We're going to see a lot of maps of Cincinnati. And fortunately, Cincinnati has 7 major treatment plants relatively closely located, and they have interesting differences that allow us to really evaluate the performance of this method in actual sewage and look at questions of dilution and degradation. These terms, Mill Creek is one I'll talk about, but that's the largest, and then there's a number of smaller ones. And if you look at the map of Cincinnati, you can kind of see this is the downtown on the river. There's fairly high density areas up here. There's kind of very green suburbs on this side, on the west side a little bit. And then on the east side, there's also a little bit of higher density, older neighborhoods. And then as you move out, this is actually agricultural land use you see out there. So if you look at these systems, I mentioned that they're different. They represent different levels of industrial flow. Mill Creek and Little Miami, they have high level, relatively high level, and the other ones have practically none, and some have, in essence, 0. There's also different amounts of combined sewer in these. These are the older networks. They were combined originally. Now there's been some redevelopment of areas with separate sewers, but as you can see, there's some combined. Therefore, these might be prone to more dilution than these. And if you actually look at Bruce Smith with MSD went through and kind of looked at the average BOD from these different plants and compared it to kind of what you think the average would be for wastewater. And you can see that Mill Creek, Little Miami, Muddy Creek, Sycamore Creek, these are all relatively old, and even if they don't have combined, they have old infrastructure, and you have a lot of infiltration during storm events, so they tend to be more dilute. Polk Run, Indian Creek are a little bit newer, no industrial flow, and relatively high strength, so not diluted. So that's a combination that we can look at as we try to evaluate the method as a function of dilution. The reason why this is important is that if you look at gene copies per liter, let's say, versus community prevalence, these are hypothetical data, but if you look at just volumetrically, you might expect to see a lot of spread due to events like storm events might dilute the signal. So in this case, if you can express gene copies per gram feces, you might expect a better prediction or decreased variability. And because you're counting for dilution, and I mentioned earlier this crassphage and the PMMOV as markers to help evaluate the method, they also allow you to kind of relate back to the grams of feces because they're both fecal indicator organisms. So that's another thing. Looking at dilution, we've both got the substrate to do it. I mean, the test design, the different systems to look at different levels of dilution. And we have techniques that can normalize for that dilution. So that's something that we are working on. The final thing is you have to not only look at the sewer dynamics, you got to look into the community. And here in particular, you have to look at the infection rates, because if you're going to look at these different sewer sheds and look at the signal and look at the level of dilution. You also need to know some estimate of what's getting into the sewer. And as Mia mentioned, there's a lot of uncertainty about what viral shedding is, but you kind of start with the best predictors that we have in terms of what the infections or hospitalization rates are in your area. Now, this graph illustrates that when we first went out to Hamilton County, the local public health officials who have been very good collaborators as well, they gave us the data, but it's and the zip codes don't really fit the sewer sheds, right? But they were able to convert that data, and now they provide weekly data on the cases by the sewer shed and even in sub sewer sheds, right? So here's the big Mill Creek, and we can actually look at variation within the sewer shed and look at kind of sewer network monitoring at some of these locations as opposed to just the central point. And this is going back to, again, if you see where some of these high density areas, these tend to be the higher density kind of working class neighborhoods in Cincinnati as opposed to some of the suburbs. So the other thing that they provide too is data on where the hospitalized cases are. So the previous data was where the non-hospitalized cases were and where the folks are living at home, but also where the distribution is and what sewer sheds and sub-sewer sheds are receiving the load from sewers and hospitalized patients. So we have that information as well. And kind of the summary of our approach is that we're correlating the weekly signal at the sewer shed. We're taking those samples at every one of those 7 major treatment plants, and we're looking back at relating those to the correlating to the levels, current cases in home or hospital. And we've got samples archived from the beginning of May. In addition to that, we're doing targeted sub-sewer shed sampling, as I mentioned, to areas of high localized confirmed cases. And we feel this is a stronger signal for the method development. It simplifies the dynamics so you could disentangle some of the sewer impacts, but also because you're monitoring it with, very shortly after it's been deposited or into the system. And then also, it's really a use case. It gives us experience to look at some of these more focused, targeted community monitoring, maybe for communities where you think are at high risk. So one other area of the work that we're doing is within, this is a map of Ohio by county about the cumulative number of cases per 100,000 people. The green is the highest. I haven't showed the legend on this, but both Marion County and Pickaway County stand out as the hot spots in terms of per capita infection rates. And that's because there's been extensive testing done of correctional institutes in each one of those counties with basically high levels, almost 80% of the inmates infected. So these serve again as very good, not only sources for the method development because you got a strong signal, but also because you have a very well characterized, more extensively tested population than in some of our, like the MSD area that I mentioned, to help really evaluate some of the models that Mia mentioned. So we're looking at these specifically for both, look for method development and for kind of model evaluation. And then since I showed Ohio, I just wanted to end here with talking about the effort that state Ohio is the governor asked us to basically the state EPA to develop a state-based wastewater surveillance effort. Asked it on Memorial Day because that's when we had the first meeting. And now the Ohio EPA-ORD and the Ohio Water Resources Center, which is a federal entity, but it's on the Ohio State campus. And their role is coordinating state university researchers. And we're trying to develop that network for a phase 1 surveillance plan where we begin in July, sample about 50 sites at least weekly across the state, probably initially focused on the metropolitan areas, but also at-risk communities. And I think this, again, illustrates bringing together the environmental scientists, the wastewater engineers, and the public health professionals together to really try to develop meaningful data. And I guess end with, this is a list of the potential involvement from the state. Susanna is leading the efforts from the Ohio Water Resources Center, and then a number of researchers from universities across Ohio. And I'll just kind of end with this graphic of, I think Mina mentioned this, right? I mean, if CDC now currently uses information from above ground, right? From hospitals or testing centers, and feed that into that color wheel in the upper left, right? Where you're kind of looking at multiple sources of data and evaluating what the trends are. Well, what we're really trying to do, and this is in the words of Jirtan Medema again, is really look above ground and below ground, really, right? Looking at either the sewer, both more localized where that red line is, or more at the centralized location where the green line is. Thank you very much.
Thank you very much, Jay. Great. And we have one more poll question here. Oh. Do we have it, Monica?
Sorry, just a second. My computer was frozen, so it happens to all of us at times. Hold on just a second, sorry. Okay.
We could, okay.
Okay, you should see it now.
Yes, thank you. So the question is whether your agency has submitted samples for analysis of SARS-CoV-2. With the option of not applicable, you don't work for an agency. Yes, no, unsure, or other. And the other, if you could write in the chat box. Thank you very much. We'll give just a minute here. All right. So it looks like the majority have submitted samples, so that's very interesting. The number who have not, and a number who are unsure. But excellent. Well, thank you very much. And with that, I'd like to introduce our next speaker, Dr. Mark Starr. Mark was reappointed by Governor Newsom in 2020 as a Deputy Director for Environmental Health in the California Department of Public Health. Since 2012, he's led the Center for Environmental Health, which encompasses food and drug safety, cannabis safety, radiation safety, and environmental management programs, as well as supporting laboratories. He's also been serving as the Acting Director of the California Department of Public Health's Office of Health Equity since August 2019, and he's the designated State Environmental Health Director. Mark has also been an adjunct professor for the Masters of Public Health program at UC Davis since 2004, and he previously taught courses in epidemiology and public health at other universities. He served in numerous leadership roles for various organizations in public health, veterinary medicine, and other areas at national, state, and local levels, currently including the Council of Advisors for the One Health Commission. And with that, it's a pleasure to welcome Dr. Mark Starr.
Thank you very much, Greg. And thanks to CASA and CWA for inviting me to participate in this panel discussion today. It's a very exciting prospect for public health and surveillance. And so we're really happy to be part of this discussion. So what I'm going to do is share a little bit about just what kind of a tool this might be at the state level for public health surveillance. And really, I'm going to focus on just a little overview of public health surveillance, basically how it works at a high level, and provide a basic understanding of how we use surveillance data to do what we do in public health. And I'll give a few examples of some of the data we have currently for COVID-19 surveillance and give you a little update of current numbers and status in California. And also provide some examples of environmental surveillance strategies that we use for some other diseases, just so you get a perspective on that. And then we'll talk a little about wastewater detection and some of the things you've already heard about, but just from a state perspective. So just a kind of a quick overview of where surveillance fits in public health. On the lower left there, the surveillance is the key to everything else we do in public health in many ways. And as an epidemiologist, of course, I'm biased, but we really have to understand the data and the evidence and the problem before we can figure out what's causing it, what we might do about it, and things like that, which Mia alluded to as well in some of her slides. So this is kind of a standard definition for public health surveillance. I wanted to mention that our patient in public health is the population, not individuals. And so that's really what our focus is and why surveillance is so important. This large definition here is very detailed, but it really just refers to the analysis, collection of data, evaluation, and using it to solve problems. And so I've always liked this very simple definition as information for action. That's really what surveillance is about in public health. So there's a number of uses for public health surveillance, not just tracking courses of illness, but a lot of other things that are listed here. I'm not going to go through all of them, but there are some that have particular relevance for wastewater detection of coronavirus. So the second one there, detecting epidemics and problems. Obviously, wastewater detection could be a useful tool for that. Estimating the magnitude to some degree, as you have heard. Measuring trends, ups and downs, maybe our first indicator through wastewater surveillance. And monitoring changes in the agent itself, as Mia alluded to. And then, of course, assessing effectiveness. Is this useful for making decisions on our measures to reduce spread of the illness and the infection? So whether it's stay-at-home orders or other strategies of closing different parts of our economy and businesses and gatherings, of all of these things, perhaps wastewater detection could be useful to evaluate along with our other surveillance tools for coronavirus. So a quick surveillance update. As of Sunday, we had just over 151,000 cases had been reported in California and a little over 5,000 fatalities. This particular slide is a very cool mapping graphic that's available on our website. And I have up here the link for various things that I'll show you if you want to look at them later. And you can click on these various buttons. This happens to be the display for new cases across the state. You can do just positive cases total. You can do total deaths, new deaths. And you can also actually show it by county. So it's not a per capita or case rate, it's just the actual number of cases. So obviously there's more in LA area, but it still is a useful tool. And it's potentially, you could think of perhaps someday there could be a button up here for wastewater detections in various areas of the state. Here's tracking hospitalizations in California. And as Mia mentioned, that's part of the surveillance pyramid is hospitalized cases. And for coronavirus, it's one of the most useful tools that we have simply because early on we didn't have widespread testing available and not everybody accesses healthcare quickly. But hospitalizations are a fairly regular fraction of a particular disease. And so this is a useful tool. You can see we're generally trending downward. And I have an odd message popping up, but it's going away. So it's the total hospitalizations is this black line here. And then there's other information on this slide. This is about how many of the patients are in the ICU. And so we have hospitalization data as well. I don't really know. Anyway, we'll move on. I don't know if you're all seeing this. I have a thing that pops up, says, please move this window away. But if it keeps popping up, I apologize. I don't know what that is, but
never seen it before, Mark.
Okay. Anyway, so here's a display, a tabular display of some of the data, again, on as of Sunday. This is demographics. We look at demographics for cases as well as fatalities. And this happens to be race and ethnicity information. And we're certainly all very aware, I've circled here, this is African American percentage of the deaths due to coronavirus in California. And you can see over here to the right that it's about 1.5 times higher than the percent of African American population in California. So definitely disproportionate in the fatalities. And so there's a number of disparities in our data. If we look at the Latino percentages are about the same here, but when you look at more tables on this webpage that have age categories, we see that there are disparities among both our Black and brown populations, and they're different by different age groupings. Some of the explanations, of course, are that many of these folks may be more essential workers. They have more frontline contact with customers and the public. There can be housing difficulties or housing densities that facilitate transmission. Access to care and healthcare and testing, all those things can affect how these demographics play out. And then this is another tool. This one is used for reopening. So I'm just giving you kind of a snapshot of a few things. But this again is statewide, but you can go up here and select the county if you want to look at individual counties. And this is looking at specific indicators over the last 14 days that need to be trending in the right direction in order to be reopening or to maintain opening. And so we track all of this, including this one right here is percent of test positivity. And that's a reflection of not only how many people are testing positive, but also the availability of testing. And our goal is to keep that below 5% for both reasons. So this is just kind of a summary of various data sources that are used for surveillance. We're not going to go through them all, but we just talked about with coronavirus is case reporting, notifiable diseases, hospitalization data we looked at, and a little bit about laboratory specimens. And these are kind of bread and butter public health reporting, and they all go back to individual cases. But we also do things called like sentinel surveillance. And that's where some of the environmental testing falls in and where wastewater surveillance would fall in. And so some examples of sentinel surveillance are listed here. We don't necessarily look at individual case, but we look at sites or particular providers or something in the environment, whether it's vectors or animals. And so an example is influenza surveillance. We don't have case reporting for influenza. We use sentinel providers that provide us counts of influenza-like illness that they see during the season. And we also have laboratories that have done specimens and tested for influenza. And so there's different ways of doing surveillance. And this will probably overlap with coronavirus surveillance when we hit the influenza season again, since there's similar illnesses. We also look at vector-borne diseases. The example here is ticks. We can test ticks for example, the bacteria that causes Lyme disease. And that's another one of our surveillance tools. We'll collect ticks in certain areas and test them. One of the most interesting examples that's very timely right now is the West Nile virus season starts to crank up. And if you want to, it's hard to see here, but westnile.ca.gov, there's lots more information there at that link. But West Nile is interesting because the natural cycle is mosquito and bird maintenance of this virus in nature. And some birds actually get quite sick and die from it. Other birds are minimally affected. So one of our most useful surveillance tools early in the season, before people are affected by mosquitoes or horses, is dead birds. And so that's an environmental testing tool. We'll gather dead birds early on. We also test mosquito pools. And we have this interesting thing called sentinel chicken surveillance, where we have chicken flocks around the state that have not been exposed to West Nile. And we draw blood periodically and look for antibodies. The chickens themselves are not particularly affected, but they do seroconvert. And so we use those antibodies to identify regions where the virus has appeared. And all of these things tend to occur before we start seeing human cases. So they're very useful tools for surveillance. And you can see the concept and parallel to something like wastewater testing to be able to have something environmental and an earlier detection before human cases appear. So these tables are from, some of these surveillance slides are adapted from CDC, and this is one of them. And the next slide also, just a list of surveillance system attributes. I'm definitely not going to go through each one, but these are the things we evaluate surveillance tools with to see how valuable they will be for public health. And so the one example here that's very important is data quality. And so you've heard a lot about the importance for wastewater testing of data quality and how that's going to be determined and all the parameters that have to be evaluated. Timeliness is one that may have a big advantage with wastewater testing, as you've heard. It could be an asset over case reporting, for example. And the experience in the Netherlands supports that. Some of the other things that are important for surveillance systems is, for example, sensitivity. Now, again, this table is really focused on case surveillance systems for human cases, but sensitivity in terms of the laboratory testing, the ability to detect the virus in wastewater streams is an important aspect to be considered here. And then maybe perhaps the most important one to us from a public health perspective is representativeness. And how is this testing and detection really representing the population that's under surveillance? And Jay just showed a whole bunch of examples of how they're looking at that and trying to link it back, basically upstream. We have many other examples of environmental testing that we do. We test food commodities for pathogens, for example. We look at biotoxins in the ocean and the organisms that produce them because they can cause shellfish poisoning. We do radiation air monitoring around the state. We do air quality. So there's lots of examples of environmental testing, but we haven't done too much with wastewater detection, especially in California. So this would be relatively new to us. It's been used in public health for polio monitoring and polio control efforts in the past. There are some differences, of course, with polio being a much more route of transition is fecal oral for polio, and there's a large shedding from cases and for a long period of time, and there's actually almost all of the infections are not significantly symptomatic. So polio has some of those advantages, but we're familiar with that, and there's been some research in Sweden about looking at detecting hepatitis A outbreaks and some other potential pathogens such as norovirus before they actually occur in the community. So this is something that's been evaluated in public health to some degree and used. So what's the added value for us in public health and the utility? You've heard from Mia about either early or late in the course of an outbreak, emergence or reemergence. If we think it's been eliminated, would obviously be a huge value to not have to be testing large quantities of people, but be able to look at their community through wastewater detection. In situations where there's limited access to healthcare or testing, some communities that obviously would have value for testing that community in that way, and just monitoring trends over time. This really is a pooled sample, and as Mia mentioned, it includes asymptomatic shedders. So allows us to see where the infection might be occurring if this tool is fully developed. But we do need national standards, and we're just extremely excited about CDC's and EPA's work that you've just heard about. The efforts to evaluate and coordinate this testing and all the research that's going on is extremely interesting to us, and it is a possible tool if this is all successful for surveillance. The standards, of course, in the areas you've just heard about in terms of testing and sampling approaches, the QA and QC and validation methods for looking at inhibitors and tracking surrogates or comparison viruses, such as the endogenous markers that Jay was mentioning. So all of these things are important, and the limits of detection is important if we're going to get to a point where we're actually looking at using this to determine disappearance. We need to know what those limits of detection really are. And finally, the models. How do we use all this to estimate upstream prevalence? That's where the real value would be for us in public health. And all the adjustments that you've heard about for inflow and dilution and human shedding parameters and all of those things, that Mia showed in her model framework. So, and also, it's useful for portions of the, oh, there's, sorry, a typo there, should be sewer shed. You know, is it portions, is it institutions, is it entire county, entire community? So all of those will be valuable for us as well. So, you know, this was just from last Friday, this headline in Tehama County here in California. And there were some test results that had been done on wastewater. And I don't think we're already there, but certainly it's being used, as you all probably know. And there's a number of private companies. I'm not quite sure why they're showing what looked like vials of blood for a wastewater test, but that's probably what the news outlet had handy. But this was, you know, definitely we think it's a detection of the virus, not a question really about that. But other than that, we don't really know what this means without the research and the other information that you're hearing about today. How do we interpret this and extrapolate it back to the community? So with that, I will stop and pass it over to Lon. Thank you.
Thanks very much, Mark. And before we get to Lon, however, we have one more poll question. If Monica can pull that up. And it's, who would you share the results of samples analyzed for SARS-CoV-2 with? And Mark, all it would apply, your local health officials, Centers for Disease Control, US EPA, or other. And the other, if you could respond in the chat box. We'll just give you a minute or so to do that. All right, well, local health officials certainly come out well. Everybody does, CDC and EPA as well, all with big majorities. And I know CDPH, the State Department of Public Health, also got votes. So thank you very much. And with that, I would like to introduce our final speaker, Lon Weiborg. Lon is the Director of Environmental Services at Orange County Sanitation District and oversees Orange County's resource protection, environmental compliance, regulatory affairs, ocean monitoring, laboratory and source control operations. Previously, Lon served as the City of San Diego's Deputy Public Utilities Director, overseeing water and energy resources planning and water conservation. And with that, I'd like to welcome Lon.
Thank you, Greg. I'm going to go ahead and assume control of my slide deck here. All right, let's see if we can forward this. There we go. Excellent. Well, thank you to CWEA and CASA for this opportunity to share OCSD's experience and lessons learned while navigating the rapidly evolving COVID-19 landscape at OCSD. So many of you are already familiar with OCSD, who we are and what we do, so I'll keep this quite brief. This is a map of our collection service area. So Orange County as a whole has about 3.18 million residents. We serve the northern and central regions of the county, which is actually the third largest county in Southern California. The area that we serve has a population of 2.6 million individuals, and that is to say that we serve a highly urbanized portion of the county, representing 20 cities. We have two facilities, one in Fountain Valley, the reclamation plant number 1, and then another facility in Huntington Beach, and that's our treatment plant number 2. And we're zooming out here so that we can give you a broader perspective of our overall presence in the watershed, that is the Santa Ana River watershed. This is important in that we've spent a lot of time today talking about possibly surveilling upstream. I believe Jay did a great job at representing sewer sheds and just essentially how geography relates to what we're talking about. And just want to let everyone know that our source control program collaborates with all of the entities within the sewershed and the watershed to make sure that we control inputs of all kinds of potential materials that we need to control. And the next slide gives you a very quick overview of our system and highlighting the fact that both of our treatment plants collect and receive materials from residential, commercial, and industrial inputs. So each plant gets a combination from those sources. And we are also a significant resource recovery facility where we have beneficial reuse of the biosolids. We also are part of the GWS, the Potable Reuse Project, where we partner with the Water District, the wholesaler of water here in the same service area, with very, very few exceptions. We basically have overlapping territories. So GWS currently reclaims and provides 100 million gallons of potable water supply for our customers. And we are undergoing final expansion, where by the year 2023, we will be able to serve up to 130 million gallons of potable, purified potable water. And we'll move on for an aerial view. So having described the relationship with GWS, you can see at the graphic representing reclamation plant number 1, we're located right next to each other. There's a significant amount of convenience, as you can see. And the final expansion will involve bringing more water, bringing more secondary treated effluent up from our Huntington Beach plant, which is 4 miles away. And that will be brought along the Santa Ana River Channel. And again, at its completion, we will be able to produce 130 million gallons a day of potable water. So GWS, of course, as you can imagine, in light of COVID-19, provides a very safe and very reliable source of water. And also our partner, the Water District, has done a great job communicating the fact that this is advanced technology that provides a safe and reliable, continuous source of water. We are happy to report that we've gotten very few questions from the public regarding the safety of the drinking water here in Orange County, and we're very excited to be a part of that endeavor and continue to support that. So a little backdrop on what's happening in Orange County. So currently we have a total of, cumulative total of 8,759 cases. And it's important to note that that is an all-inclusive number. Roughly 47% of those cases have been documented as having recovered. The raw number on that is 4,138. And all of this information is available on the Orange County Healthcare Agency website. And the information was captured yesterday. As far as new cases are concerned, even though the overall prevalence, if you rely on the previous graph, is relatively low, we're still hoping for a downward trend in new cases, and unfortunately, we're not seeing that as of yet. What you can see is the day-to-day case count continues to fluctuate rather significantly, and we commend our Orange County Healthcare Agency and all the healthcare workers for all the great work that they're doing. We do have data granularity at the city level, and the county is planning to provide information at zip code level as well as mapping function in the future. We're very excited to hear about that. So one other key question in terms of surveillance is testing. So as you can see, with the backdrop of overall population in the county of 3.18 million individuals, the total number of tests performed in Orange County as of yesterday is roughly 184,000. We can draw our own conclusion as to why, but it underscores the importance of having a large-scale surveillance efforts, potentially like wastewater epidemiology, wastewater surveillance, if you will. And then as Mark had mentioned earlier, and also Amy had typed into the Q&A section, we are seeing also some tracking of hospitalization. The blue is ICU stays. So we're also hoping for a downward trend in that regard, and unfortunately we have yet to see that. So why did OCSD decide to jump into the wastewater surveillance effort? Well, one of the things that happened was early on, shortly after the World Health Organization declared COVID-19 to be a pandemic, I believe it was early March, maybe the 11th or thereabouts, we began to hear about wastewater surveillance, and more importantly, we're seeing some really disconcerting headlines. One of which popped up on April 2nd. We were hoping that it would pop up the day before. I mean, April Fool's joke, but it wasn't. A very well-respected scientist made a statement in the press to the LA Times that really brought into sharp relief that if we remain in the audience, if you will, some of these questions will be left to others to answer. Luckily, 9 days later, in a follow-up article, some updated studies in the journal Nature refuted that the assumption that wastewater is capable, at least in Southern California, of being kicked back into the air along surf zone. We have known as an industry that properly treated wastewater does not carry the level of risk that may be implied in this article, but it was still helpful to see that. So furthermore, we as a collective decided that we wanted to consult with agencies and collaborators such as NACWA and CASA to educate ourselves on just what we can do to address some of these questions. Basic questions such as, is it safe to go into the water? And fortunately, we weren't alone in our concerns over the headlines, and a number of colleagues and others proactively shared information, and we really appreciate the webinars that CWEA has put together for us to learn all together. In fact, today, I learned a lot from our previous speakers. So the fast science remains problematic, and of course, this is something that was posted in late May, well after those relatively sensational headlines appeared in the same publication, that is LA Times. So we got a lot of questions from the media, the public, as well as our own employees during this period. And some of the questions, the most common questions are, is OCSD participating in research related to COVID-19? And when do we begin providing samples? How often are we taking these samples? And when are we going to get the results? Of course, as you know, these are loaded questions from the previous speakers. The results are preliminary, and we're still working towards refining the methods as Jay mentioned, the 3 knobs. So we began asking ourselves some more in-depth questions of starting with, what are the lessons learned from other wastewater surveillance efforts? What do we know so far? And again, using webinar opportunities and literature review, we have a very strong scientific staff here at OCSD and a lot of experience related to, obviously, operating our system. We've been here for 65 years. We got a lot of information, but we realized that we still need to get expert advice. And so we found that the criterion we were looking for is truly experience. And we were able to secure the advice from the University of Arizona West Center, where they've been working on coronavirus research in relation to wastewater for 15 years since the SARS-CoV-1 outbreak. And we also wanted to see, we're not a research institution, so what are some of the use cases that are specific to Orange County Sanitation? And one of the first things that came to mind is that we want to ensure staff safety first and foremost. Some of the questions our staff were concerned about are related to whether or not the virus remain viable, and is it, or is the virus infectious? Are we even getting that into our plant? So we felt that it was a priority. And a second priority was to support the local public health efforts. We understand that, again, we are a large regional system serving roughly 457 square miles. We can be of help if we can provide a level of granularity. And can we sustain field and laboratories resources? As mentioned by Eileen White in a previous webinar hosted by CWEA, just like other agencies, we've reduced the on-site staff significantly, well below 50% of the pre-COVID number of folks on site. We're using the same folks to do intensive work, and we're getting a number of requests from various researchers, which we'll talk about later. But we did not want to divert staff resources from critical functions to projects that may be redundant. So we instituted an intake process where we review the proposals from the research and sample requests to make sure that We understand the objective and also the potential benefits from each study and whether or not we're even the right party to provide those samples. Secondary to that, we realized that, should we conduct should OCSD conduct its own study? Because we are a large regional system, and in reviewing a lot of these requests, we realized that not every proposer understands how OCSD is structured as a system. And in order to answer the questions posed by staff and others, the timeliness of those projects sometimes do not mesh with what we felt was a responsive timeline to some of those concerns that we're hearing locally. So lastly, can we support other research efforts? We want to make sure that the way we collect the samples and store them is uniform, so that if there are any differences in the results, at least the way that the samples are being handled at OCSD is minimized as a potential factor. So we got many requests. Some, as an example, some requests want samples every single day from multiple sites throughout our treatment system. Actually, and then there are other projects that request a high volume, but only needed them for about every 2-week frequency. So we evaluated those through our internal scientific advisory group, and then we also utilized the advisors from University of Arizona to help us gauge whether or not we've gotten adequate information to utilize our limited resource to support those projects. So to date, wanted to share with you that there are 3 projects that we've committed to supporting. And I will begin with a project that have been ongoing. I will begin with the Stanford University project that I believe Mia alluded to earlier. So this project is led by Dr. Ellie Bain of Stanford University, and I believe Dr. Wiggins from University of Michigan, who were both speakers, or Dr. Wiggins was a speaker in a prior webinar. There are 3 objectives to this study as described to us. And first is to refine methods for determining presence, concentration, diversity of the virus in wastewater. And then the second objective is to understand whether or not that data could be compared to the prevalence in the area served by the specific wastewater treatment facilities. And the third would be to develop a model. And I believe Mia talked about comparing that model to the CDC model eventually. So right now, this project, as we understand, has archived over samples from over 50 POTWs within and outside of California. And Southern California Coastal Water Research Project is participating as a coordinator of sampling, and also they're working on method development for a very specific objective that is takes it beyond the 3 objectives that I described. The second project I want to share with you is actually an ongoing project that is sponsored by the California State Water Resource Control Board. So starting in December 2019, because of the effort to the state board to develop uniform water recycling criteria for direct potable reuse through raw water augmentation, OCSD, along with several other agencies, many of which on this call, we're all partners in this endeavor. We all began to provide raw wastewater samples to every 2 weeks to support the study, where basically it's looking into pathogen removal. And this project now includes COVID-19, or excuse me, SARS-CoV-2. And many of the samples that were collected since December have been extracted for genetic materials, so they could be used to look for SARS-CoV-2. Lastly, OCSD, as I mentioned before, did decide to commission our own study, and we're working with the University of Arizona. And I will talk a little bit more about our approach, but the use case for that study is focused internally as a first cut. So we wanted to see whether or not we can detect the presence of the virus at our headworks, meaning the influent. Largely because we serve a very large territory. Dilution is clearly a consideration along the fact that we have a very large collection system where we have odor control mechanisms in place. Some of those additives could be problematic. So, however, before we go upstream to look for signal, we thought the best place to begin is right at headworks. So this schematic shows where we begin. We are looking at detection at headworks. We submitted several samples that were collected since early April to University of Arizona. We have not advanced to viability or treatment effectiveness because those are dependent on the first findings. So our initial observations show that there is really high variability in spike and recovery efficiency, and Jay made note of that in his presentation as well. It's not surprising, although we were a little disappointed. It's essentially rendered the data not necessarily usable at this moment without further analysis and confirmation. We also realized that what we suspected might happen in terms of matrix interference was probably happening. These samples were frozen in -80 refrigerated. They were first frozen in -20 and then subsequently -80. We were also concerned about sample preservation effects. So what we're doing now is submitting fresh samples and archiving in aliquot to be submitted later to see if the degradation can be studied. So you heard the word modification. So we updated our research plan. And one of the things that we're looking at is to identify additional sampling locations to avoid potential interferences. We're targeting domestic flow, and we're trying to avoid industrial waste streams. We're also trying to avoid collection system additives. We will still take a look at plant one influent where the headworks is. In addition, we're revising sample storage and transport mechanism to minimize degradation of the cellular material. So we're at stage one. We're not moving on until we figure out what's happening. We would still like to examine viability, partly because right now we believe that we're reassured by the consensus among our partners that viability is not likely. However, as this epidemic goes on or pandemic goes on, I believe those questions may arise again. But first we have to find it. So we're focused on detection. And I'm very happy today that we all learned about the 3 knobs from Jay. OCSD's, very interested in supporting developing analytical methods, be a part of that process so that we have standardization. And taking it beyond analytical method, looking at sampling. So sewer dynamic goes to the heart of the sampling, as well as the community specific, targeted community, types of data and samples we wish to collect. So those 3 knobs play together critically for this endeavor, and OCSD is very excited to be a part of this project. We're also working with some of our local public health epidemiologists to make sure that what we may be able to offer from OCSD is useful and usable. So we're focused on actionable data. So going forward, I just want to acknowledge that we'll continue to seek advice from our technical advisors from University of Arizona and also from CASA. Greg has been a great help to us. And we also have regional advisors both here in Orange County, but also folks in San Diego. And then at OCSD, we have a core team that's monitoring this effort. And we will continue to adapt and learn as the situation goes on. And that's it for me. Thank you very much for your attention.
Thank you very much, Lon. And thank you very much to all of our panelists. I think it's been a great webinar. And we don't have a whole lot of time, but we do have some time for some questions. And folks should know that Amy Kirby from CDC has been doing yeoman's duty and answering many of the questions in the Q&A section. And I believe these will be available following the webinar as well. And Jay has also answered some, and of course, Mia. But to get a couple of questions in, one of the ones I guess for Mia and Jay in particular is that even if we're unable to quantify the levels of the virus, are the trends still of value to determine what is happening in the community, meaning trends, whether the presence or absence is increasing, decreasing, or plateauing? Or do we really have to wait until standard methods are established?
This is Mia. I can take a first stab just based on the data we've been looking at so far. So we do believe that trend analysis is possible. I think that we have a pretty good methods for quantification, but there's a lot of little details to work out. So we feel like that's possible in the near future. The part that requires more clinical data to be confident in is the using sewage to estimate the true prevalence in a community. So the overall infection percentage in a sewer shed. So that's what I think needs a lot more actually clinically based data on shedding of the virus throughout the course of infection. The tricky part will be working through all the nuances on the samples and what it's representing within the sewer shed to understand what is a significant trend upward or downward and what is noise in the signal. And I think that's what a lot of the researchers are working on now.
Thank you. Another question which has come up, and I think there have been some responses to it, and I know Lon referred to it and others have as well, is does pre-chlorination or other treatment at the headworks prior to the sample collection point impact the detection of the strands? And I don't know if Jay, if you might be able to tackle that one.
You know, we haven't looked at that direct, we have not looked at that directly, but this virus is fairly sensitive to chemicals and other conditions. So that would best be avoided, particularly given the lower levels of detection that we see in wastewater. You really want to try to minimize anything that might further degrade the signal.
Right.
Yeah, I would agree with that, and also say that it would make it difficult to interpret whatever signal you see, not knowing if it is there, but it has been treated, how much that signal has degraded.
Okay. And a question for Mark, and some of the data that you showed refer to the new cases. And what is the metric for a new case? What is the time period for that?
So new cases are basically newly diagnosed cases. So it's at a point in time if someone's recognized that they have the infection, and it's usually based on symptoms and a test result, and they're reported as a case, and they're not counted again the next day or anything like that. It's just each day's counts are of those individuals that were diagnosed and reported that day.
Great. And one clarifying question for you, Lon, was what clinical tests were used in the graphs that you showed for Orange County test cases? Were they swab tests or were they antibody tests?
I actually have to apologize for not knowing the answer to that. I don't know if Mark knows, but I can check with our contact at the county to confirm and get back to the person with the question.
No problem. Thank you.
Now, most of the, I can tackle that, Greg. Most of the test data in California, all the test data that we report is based on the antigen test from patients. So, the nasal swabs that you see. Antibody testing is done in special studies, mostly in people that want to just know if they've been exposed. But as far as counting positive tests, it's based on the antigen test.
Great, thank you. And then this is probably one for Mia and possibly Jay, but what level of granularity is needed if we have an increased prevalence in the influent wastewater? Can pre-treatment protocols be used to then go back up the sewer system to locate what the source of that increase might be? Like if it was...
Yeah,
yeah, go ahead.
So essentially almost signal tracking within the sewer system. I think that, that's something that theoretically could be a possibility if you have really good hydrodynamic models of your system, but it's something that would probably right now be very complicated by the different aspects of the testing and interpretation we're working on. So I think that wouldn't be a near-term application from my perspective, but I think instead there may be more targeted use cases where of a cluster and you're trying to understand what those trends might be, say, like Jay mentioned, in a prison, a nursing home, or a university. The kind of real-time tracking may be something down the line once the field has matured a bit more.
Great.
Yeah,
Thank
I would agree. I would agree. That's it's probably best. The idea of sampling in the sewer, I think, has a lot of potential, but probably not to track the signal from the wastewater, the centralized plant, but rather really ask questions about particular sites of interest.
All right. That makes sense. And another one is when a composite sample is being collected, should it be refrigerated? Like if you're getting a 24-hour composite, should that sample unit be refrigerated?
Yeah, we've had these questions or this discussion quite a bit, and I think where it makes a big difference is during the extreme season. So when it's very hot outside, you know, that heat could degrade an RNA signal. For sewage surveillance, we're not interested in infectivity. It's an important question, but not for this application. But those high temperatures could degrade the RNA signal. So we've recommended sampling on ice for 24 hours, especially if the composite sampler is left in a heated area.
Great.
Yeah, and an additional approach potentially to minimize the amount of time that the sample may be sitting at elevated temperature. This might be particularly relevant to some of the in-sewer network monitoring I mentioned. If you're trying to capture flow out of a given residential area, for example, that you think is at risk, you may be able to shorten that window of the composite sampling, really look at the high flow period during the morning perhaps, to really compress the time that you're having, still develop a composite to get more of some integration of the signal, but not you know, long term.
Okay, that makes sense. And this may still be an unanswered question, but do we know what the lower limits of detection need to be in order to quantify the concentration of the RNA beyond just being able to detect its presence or absence?
Well, the methods, you know, you can detect very low concentration. Theoretically, you can detect very low concentrations of RNA signal or some kind of a nucleic acid signal in wastewater, as few as maybe, you know, a single gene copy per liter or so. But what that translates back to what actually came into the water, right, gets into understanding the decay, the degradation, the dilution, and what actually was shed into the sewer. So, I mean, the question of going all the way back is complicated, but you can't, you know, theoretically, you can detect very low levels.
Yeah, and I would say in practice right now, we've seen detection limits that are hovering around 10 to the third, so about 1,000 copies per liter if you take into account recovery as well as processing. Because when you do the testing, you do all the concentrations that Jay mentioned, and so you're only actually testing a subset of that 1 liter sample after the concentrations. So that's where our effective detection limit seems to be right now, but there are definitely a lot of detections in wastewater systems right now because there's a lot of cases. We've been speaking with other countries that are now in a case-free period, which makes it a very interesting discussion about how they might be approaching sampling in volumes and needing to process tens of liters in order to have a meaningful interpretation of that, which makes the methods different and standardization change.
Excellent. And another question is, I assume that it is accurate to say that when doing the analysis, you really need positive, negative, and inhibitory controls in order to ensure the accuracy of the result?
Well, I would say certainly you want to run inhibitory controls for looking at what might be interfering with your PCR reaction, which we didn't really talk too much about today, about that side of it, the analysis part. But you certainly need that. In terms of a positive control, I mean, that's where we're using spikes of different surrogates. It's hard to, you know, you're not going to spike with the actual SARS-CoV-2.
Right.
Any routine method. So a positive control, I'd say yes, but you're always going to be close to some surrogate for a positive control, with the caveat also understanding that there's, when you use those spikings, you get this, like I mentioned, this rapid decay, immediate loss of signal, which with some of these envelope viruses. So it's hard to interpret that. So now,
yeah, and I think that's it.
Go ahead. I was just going to say, not quite as simple as when you have a chemical method and you just spike in, right? A positive control, you put it in there and it's pretty straightforward.
Yes. Mia?
Yeah, and I think the recoveries can be different whether you're looking for recovery of culturable spike controls or molecular targets. You know, we've also seen that there's quite good recovery and persistence when just looking at those RNA targets. And so it's something to be careful when thinking through the interpretation of what your recovery is telling us. But we do feel like the matrix recovery and understanding the process really is really important, especially if we ever want to get to estimating prevalence from a sample, as Mark mentioned, would be so helpful for public health officials. But we know that if we're only capturing 1% of a sample or 10% of a sample, that's going to underestimate that prevalence by, you know, 2 or 1 order of magnitude in that estimate. So it's important to understand how your method performs and how precise your quantification might be.
Excellent. Well, thank you. And just as a closing request, I guess, would be any agencies who are conducting these analyses, I think it would be of tremendous benefit if you would share those results with Mia and Amy and their team at CDC so that we can start this national repository and help the interpretation. And with that, I think that we can close, but I thank all the panelists again. Wonderful job. I think a very informative webinar. And Arvind?
Thank you, Greg. Yes, I do want to thank all the speakers and you, Greg, for all the great topic and discussions. I want to let every attendee know that you can earn 1.8 contact hours if you have attended this from start to finish, or even have heard the audio. You can get the contact hour certificates by going through mycwea.org. This will be available within 1 to 2 weeks. For more instruction on accessing your certificate, you can click on the link. Next slide. And again, I want to thank all the speakers. I want to thank Greg for moderating the webinar, and all the CWEA staff who have been very much hard at work making this possible. And not last but not the least, all the attendees really appreciate you attending this. This has been very successful and very good discussions. There will be a feedback. There's a link there. If you could take that survey, that would really help us improve and get the feedback from you. This link will also be available through the email that will go out from CWEA. So would really appreciate if you guys can take a few minutes and take the survey. And once again, thank you everybody, and you have a good rest of the day. And that concludes the webinar today.
Thank you.